Welcome, everyone. We're really glad to be with you today. Sorry for a few technical challenges to begin the media briefing, but we're excited to be here with you today. And this is really our an important, I think, opportunity for our new Cooley COVID-19 collaborative to share with you some of the updates to the assessment process for sharing data and recommendations around COVID-19 for our community. So I'm joined today by Dr. Todd Kowalski, who is an infectious disease physician from Gunderson Health System, as well as Dr. Kevin Fitzgerald, who is a family physician from Mayo Clinic Health System. So thank you both for being with us today. Again, this collaborative spans Mayo Clinic Health System, Gunderson Health System, and La Crosse County, the health department. So we're really glad to be a part of this collaborative to come together and support our community. Today, we're going to share with you some details about the collaborative COVID assessment process so that you have a better understanding. In addition to the latest data and recommendations for the community, as well as sharing a brief look at a new web resource that will be available soon. So we're going to start with Dr. Kowalski. Dr. Kowalski, I'll turn it over to you.
Thank you, Jen. And really what I'd like to start with, and the first thing I'd like to say is to remind everyone why we are here as a collaborative. We have been learning and evolving throughout this pandemic to find what are the best solutions and the best paths forward, and this is one more step in that process. The Compass was a very helpful tool for this community in this region in the early stages of the pandemic. And as we've progressed with new guidance, new evidence, and new resources, it really gave us an opportunity to take a look of what are the tools that can move us to the next phase that's best to serve our communities and our region. So we've worked together as a collaborative pretty intensely in the last few weeks to review the evidence and come up with a new process. It is rooted and based in the Harvard Global Health Institute system and data, and then it's been adapted to really fit our state, in our region, and our healthcare system, so it's a little more, I think, pertinent and probably helpful to our communities in general. I'd break this down into sort of two types of data that we'll be focusing on. There are primary sort of key COVID metrics, and then there are secondary community indicators. And I'm going to just break down what that means in general and then a little more specifically. The key metrics really reflect disease activity, and they reflect it in the sense of the daily case rate per 100,000 people on a 7-day rolling average, and disease activity as reflected in daily hospitalization rate per 100,000 people on a 7-day rolling average. And then we also look at healthcare's capacity and capabilities to really respond and meet the care needs of the community and the region. So those are the key metrics that we're looking at in terms of the COVID outcomes. We have also 6 secondary community indicators, and these really answer the question, how are we performing on those 2 healthcare system and public health actions that are most important to minimize and stop the spread of the virus in our community. So those 2 actions are testing and case contacting. And those are really the key things that we're emphasizing here. Those secondary community indicators give us an opportunity to look and see where are there areas for improvement, where we should be putting some emphasis and efforts collaboratively to get better. As we've gone through this process, we've agreed on both the framework and the metrics, and we've agreed to review this data weekly. And that really gives us an opportunity to give a more nuanced picture of things that we may know be behind some of the metrics and the data, and make sure we're having the best and most complete picture to drive recommendations for our region and community. We can deliberate, and it gives us some flexibility to make sure those recommendations are right. And I'm really confident that doing this together, we're going to ultimately end up with a better product that serves our communities and people well. I'd close on a positive note. Cases have been flat, so that's a real positive thing, and I think that's really a direct reflection of the actions that our community members and our communities have taken in terms of those three so important individual actions that make a difference: masking, distancing, and hand hygiene. As an ID doctor, I can't tell you enough how big of a difference they make. When I first presented on this topic in February of 2020, it was infection control and features like that are how we win the war, and that continues to be the case today. So with that, I'll close my comments and turn it back over to Jen.
Yeah, thank you, Dr. Kowalski. Appreciate that overview. There is a lot of data, as Dr. Kowalski indicates, that really supports the recommendations that the collaborative will make together going forward for our community. And one of the important ways that we can support our community is to make sure that there is a visual location where you can see these metrics and maybe even some graphs that associate with these metrics. And so we are working right now on a web resource, and I have a demo for you today of that resource, and we hope that that will go live within the next week. It is created in a system called Tableau and is something that has to be positioned on our website. So we are currently working to do that. The sneak peek that I'll share today will be available by screenshots in the same format that I show you today at our website in La Crosse County. So it's lacrossecounty.org/COVID-19. It should be right there on our homepage. And again, we hope to have the full site launched by hopefully this time next Friday. So at this point, I'm going to take you through a few slides to show you what that new web resource will look like when it goes live. I'm just going to pull that up here. So you should be able to see my screen, and I have this again on PowerPoint slides. What you're looking at here is the home page for the web resource. You'll see the name of the collaborative, Cooley COVID-19 Collaborative, and a description essentially of the collaborative. Next, there'll be a tab specific to metrics. And as we previously shared, Dr. Kowalski talked about metrics 1, 2, and 3 in terms of the new case rate, new hospitalization rate, and care capacity in our healthcare systems. This is exactly what the web resource will look like, but it will be interactive. So if you were to hover over one of these indicator lights for each of these metrics, for example, it would tell you additional information, but we've also posted it here as well, and it will show up just like this on the web resource. So for example, with metric 1, new case rate on a 7-day rolling average, right now that case rate is 10.17 new cases per 100,000 people per day. And below each metric, you can see there are thresholds listed, so that that identifies really how the indicator light for that metric gets assigned. And then you'll see with new hospitalization rate, 0.85, so very good in that regard, and COVID care capacity similarly meeting what we're hoping to meet in that category as well. Below this portion of the web resource, in this same tab, when you get to see this live, and we'll hopefully have that for you next week, will be a graph that helps you see over time where case rates have been. So this coincides with the same threshold colors that the Harvard model identifies. So you can see, as Dr. Kowalski indicated, that we have been very stable here with our new case rate for several weeks now, which is really good. Actually a month, a little over a month. So that's really good to see. Additionally, then the next tab in this web resource will look at the community indicators. So there are 6 community indicators. Metrics 4 through 6 relate to cases and contacts. It's important that we track and share with you what percentage of cases that we can interview within 2 days. Our goal is 85%. You can see we're doing very well with that goal right now. Metric 5 is identified contacts that are traced by percentage. The goal is 80%. And again, doing well there. Contacts reached within 1 to 2 days. So these are when we reach the cases, we ask for who they may have been in close contact with, and then those are the contacts that we need to connect with so that they understand what they need to do to try to decrease the spread of COVID in our community. The last three metrics relate to testing. So we're looking at a percentage of our daily testing goal. This number will change, and that is appropriate for it to do that. So the current daily goal is 107.7. And you can see we're really doing very well with our percentage of tests. In addition, testing turnaround time, though this shows a caution light at the moment, we have been improving over the last several weeks with this particular metric. So we're glad to see that heading in the right direction. And finally, positive test ratio by percent. And we are currently at 4.6% positive, and our goal is less than 10%. Just to note that in order to make sure that we are always up to speed with the most evidence that is out there and available at the time, we will always tell you that this is subject to change, because as a collaborative, we need to make sure that this is, again, aligned with the best evidence at the time, and that evidence does change. And so we need to be fluid and change goals, for example, or maybe even metrics as time goes on, and we will always describe those changes and a reason for why. Then below that section of the community indicator tab, there will be graphs as well that help support those metrics. So these are just a couple of graphs that share with you the percentage of tests that were positive, again, the 7-day rolling average over time, and the number of tests that result by day for La Crosse County. The next tab on this web resource will be a guidance tab. This is where the collaborative will look at the data each week and will identify what is that data really telling us. We'll provide a description of that. Here, that is showing up in the second paragraph, and Dr. Fitzgerald will go over this a little bit more in detail in a moment. And it will also provide some recommendations, which may change each week depending upon the data. And finally, we've always had case data on our website. We will continue to have that. This is specific to La Crosse County and comes directly from the case interviews, and we want to share that and continue to share that with you all. And where there will always be a travel tab as well to help provide some guidance about travel. So those essentially are the tabs that you will see within the web resource that, again, will be live as of hopefully next week around this time. And again, we will update that each week, and we will plan to share that with you, that live web resource next week, as long as it is ready to go. Next, I'm going to turn it over to Dr. Fitzgerald.
Thank you, Jennifer. And I just, take this opportunity to thank Dr. Kowalski and Jennifer for all the hard work they've put into this. They've really done a remarkably good job. Well, the Cooley COVID-19 Collaborative uses the Harvard Growth Health Institute model as a guide for assessing the level of concern with COVID-19 in La Crosse County. Jen Rybalski showed you the most recent update of that. Again, we are at 10.17, which is in the orange range, just 0.17 above the yellow. Please note that while previous COMPASS risk assessment model provided an overall status, the current process will share data and recommendations without an overall indicator light. Based on metric 1 for the week ending 8/11, our current new case rate is 10.17 as stated per 100,000 people. The trajectory of the new case rate is stable without significant change in the past 7 days. Our new hospitalization rate and ability to care for all patients is at a satisfactory level. When looking at the community indicators, which include public health and testing metrics, all but one are satisfactory at satisfactory levels as well. Though our testing turnaround time is in the caution zone, that is improving, and really the healthcare systems, I think, have a good turnaround with their testing. The community testing has improved remarkably. The Cooley COVID-19 Collaborative forecasts that our overall status is improving in La Crosse County. Given the information from these metrics for La Crosse County, the Cooley COVID-19 Collaborative recommends the following to assure a safe and healthy community. Stay home if you have any symptoms of COVID-19. Now, with the exception of if you're sick enough to need medical care, please seek medical care. But if you are having symptoms, please stay home to minimize the spread. Wear a mask when in public, when you're outside of your household. Keep 6-foot distance from others outside of your household. Wash your hands frequently and avoid touching your face. Avoid unnecessary travel to areas and communities that have higher case rates, especially communities in areas that have had major outbreaks. Limit personal social gatherings to up to 50 people indoors or 100 people outdoors. And again, we would want to continue with masking and physical distancing in those settings. Minimize mass gathering within businesses, public buildings, and spaces to up to 50% of capacity with using the masks and physical distancing, or the max numbers consistent with social gatherings as listed above. So meeting within businesses or in our hospitals or in our public school districts, avoid gatherings within those entities greater than 50 indoors or up to 100 outdoors, and no above 50% capacity in any particular setting. And keep in mind that these targets may change over time as our understanding evolves and as science leads us to different ways of looking at this.
Thank you, Dr. Fitzgerald. And just to close here, to let you know that going forward, we will continue to provide these updates to the key metrics and indicators each Friday. You will receive those updates along with recommendations that correspond with what the metrics and indicators show us for that week. Just as a note that the health department has previously been providing daily case updates, daily numbers, and we will no longer do that starting Monday. We will move to a weekly case number summary, and then we will try to share with you what trends are occurring. That's really where the important information is, along with what the data overall is telling us and how that guides our recommendations and our actions as members of this community. If there haven't been significant changes over a week, for example, then there may be times where we will not need to do a media briefing. We do plan to do one next week to be able to launch the new site. But again, if we remain stable and recommendations or metrics don't change significantly, then we would just share that information with you by a media release, posting it on our dedicated website that will be hopefully launched next week, and also on social media. So at this time, I think we will open it for questions from our media partners.
Hello, Marcus with News 19. So why do you guys think that people should be able to trust this new system?
Well, I can start, and then Dr. Kowalski or Dr. Fitzgerald can share as well. I think that's a good question. And what I would say is that, this system is based upon the Harvard model, and the Harvard model is a very solid evidence-based model. And actually, our state as well has been using that model to support the data that they are sharing. So I think what's important is having something that is evidence-based and can be consistent more than just even in our county or our region. So I think that's one important reason why. In addition, I think the data speaks for itself, and many of these data points are not significantly different than we've reported on in the past. It's simply allowing the data to speak for itself and sharing recommendations that specifically relate to where that data tells us we are in any given week. So we think that this will really provide that level of support for our community, both to understand what the data says and to know what to do because of what the data is telling us. Dr. Kowalski or Dr. Fitzgerald?
Yeah, I'll just jump in and say that, in healthcare and in all health kind of issues, we always rely on the evidence, and as the evidence changes, we adapt and change with it, because that's how you get the best outcomes, whether it be for a patient or in the case of public health, for your communities. And really, that's what this is. This is an extremely reputable group that we founded it on. It aligns very nicely and closely with the state of Wisconsin. So we can have metrics that really are consistent when we come up with our guidance. And it will be an iterative process. So it will be a process where when we learn more and we can do better, then we will change it and make it better yet. That's the nature of healthcare. That's the nature of the COVID pandemic. And so I have great confidence in this approach to moving forward.
I would echo what Dr. Kowalski said. I think this really closely follows the local epidemiology. It follows where the virus is over a period of a week, and we can address that on a week-to-week basis. I think the other thing that really was brought to the forefront is that we wanted to make sure that our recommendation is going to follow what really is important in treating and preventing illness in our communities. So for example, the number one goal for us as healthcare providers is to avoid our hospitals and especially our ICUs from being overrun by severe cases such that people are not getting adequate medical care. And, that's one of our primary concerns, is that we are responsible for the overall public health, but we do not want to have our facilities overrun with cases that we can't take care of. And I think we've done a very good job of that here. Both medical facilities and Ms. Rumbalski and her team at the county have helped with that. I think this is going to bring us forward and be a little more nimble to allow us to guide where the community should be on a week-to-week basis.
We have a question from Tyler at WKBT. It's a two-part question for the group. What makes this COVID-19 risk assessment better compared to the COMPASS? And was the COMPASS accurate or inaccurate when determining risk level?
Yeah, so again, I can start and then Dr. Fitzgerald and Kowalski can join in. So again, I think better or worse is not the right terminology to use here, just different. So when you looked at the COMPASS previously, again, some very similar metrics, not the same, but similar in the categories that we want to be looking at. But the COMPASS included a measure to be able to identify an overall indicator light, and that inherently caused some challenges and was not as nimble as it really needs to be going forward with a pandemic. And when you tie that directly to recommendations, it doesn't allow for assuring that that always remains accurate and pertinent. So I think it's about flexibility. And as we've already talked about, making sure that we are aligned with the most recent evidence, which this process is, as well as being flexible and making sure that what we're providing to the community is both stable in the metrics that we're sharing and the data that comes with those metrics, but then also can allow for the understanding of what we may know about our community, that metrics and data, can't, they give the objective piece, but can't speak to some of those other aspects that we know about our community. So the collaborative will be looking at all of these metrics each week and supporting the community by pulling together what that data really means and how that equates to actionable recommendations going forward.
Yeah, I think, when we kind of answered the first question with our first answer, the COMPASS was a really useful tool when we first had to, express what we needed to do in our community early on in the disease. As we learned more about it, and again, I think as we got more knowledge with the virus, I think focusing more on the actual epidemiology and having that guide a lot of our recommendations versus really how we're reacting to the virus, I think is where we'd like to go. But again, I'd like to echo that the COMPASS was really important in especially flattening the curve early on in our experience with the virus. And our community did really well with that as opposed to other communities like New York City and some of these other places that really struggled in the opening months of our experience.
Agree. I'm going to build upon Jen's comments a little bit to kind of make this hopefully really clear in people's minds what we're getting at. Let me give you a couple of examples, one related to cases and one related to healthcare that have happened across the nation and across the region, that this tool is going to give the ability for us to do better. The first may be case rate. So if there is and this has happened across the nation, when there is an outbreak in a closed facility, those case rates may go up. But if it's in a closed facility and there's nothing happening on the community level, that's a big issue for that facility, and we need to take action. But at the community level, those case rates may not reflect an overall risk or burden or situation in the community. So when we're able to have the conversation, we can have that discussion about the cases, where are they at, where do priorities need to be. But we can also have the nimbleness to understand what that means in terms of recommendations. Similarly for healthcare, there are metrics and important metrics reported out nationwide, and you can find them in the news about ICU capacity and healthcare capacity. Those are pulled from databases and repositories, and they're an important public health tool to understand at a high level. But at the local level, in addition to just using that data, we can literally have a conversation with each other and with public health, and to know, here's what the data shows, here's what the inner workings of healthcare are, here's where we're really at in terms of our capacity, so we can be making the soundest and wisest decisions. And those are two examples that this tool allows us to do that the Compass really just wasn't designed to do it at that like we need now.
Okay, so when you're referring to this tool, is it a collaborative? Is that the tool that you are referring to? And I do see like the orange, and there's still those 3 light categories. What metrics are different there versus the light that we would always go back to with the Compass?
Yeah, so again, the Compass had 3 buckets of information. So it had an epidemiology bucket, a healthcare bucket, and a public health bucket. This now has 3 metrics that really show us on the rate side, what is the burden of disease in our community, and are we in jeopardy of overwhelming our healthcare systems? And then the second tier of metrics helps us see what those practices are that help us make sure we understand how many cases we have to support that case rate being accurate with the testing pieces, as well as are we reaching cases and contacts quickly enough to decrease spread in our community. So it's a different way to look at some similar metrics. And again, the Compass had a mechanism to pull all of those together into an overall indicator light, which, while we know that has been helpful to our community, we don't think that that is best going forward because it places too much emphasis on a single light, that it just isn't quite that simple. So those 3 primary indicators or metrics will have a light based upon the thresholds there. And the Harvard model shows those 4 colors for the rate, for the new case rate. And so those will have an indicator light for each of those metrics, but there will not be an overall indicator light on purpose, because that allows us to share the data as it is with our community. And then in the recommendations and guidance tab, you will see what the analysis is, so to speak, of the data from the collaborative, along with the recommendations that align with that analysis. Others who want to chime in?
No, I think that's well said.
Concur.
Dr. Kowalski, you referred to nimbleness a lot, and I've heard others talk about that as well. What do you guys mean when you say the collaborative is more nimble?
Yeah, great question. So I think it's nimble in a couple of different ways. Number one, and probably most importantly, the collaborative members will be meeting weekly and having the discussion and really allowing that full perspective, so we can have make adjustments as need be. I think another thing about this tool, and Jen spoke to this, but I'll just reiterate it, is it is not a if this then that type of formula. It is not a this color equals these responses. And so that allows us, nimble, flexible would be the words that we take the data is what it is, but people interpret the data to make sure we have the right context and understanding, and then we make recommendations based upon that. And I think that is going to be a more informed and a better recommendation. It's going to be a recommendation that allows us to understand that the factors may look one way. In reality, we can make a different recommendation. So that's the idea here.
And I will just add to that to say that one of the parts of this process is also to meet with a group of community stakeholders, which we haven't talked about a lot yet, but that will start next week. And the purpose of that is for the collaborative to have an understanding of what the data shows for that week, share it with that group of stakeholders, talk through the recommendations. If there are any changes, like to the thresholds or to the metrics, we can describe that to that group. We can get feedback from them to make sure it's understandable. And that provides a linkage with parts of our community in a way that wasn't there before. Additionally, I think, this is a team effort, and I don't mean just the collaborative or even the collaborative and the stakeholders. I mean the whole community, that this is not something that just we do. This is something that you all help us do. This is a community that has to work together, and it isn't we tell you what to do and you do it. It is, here is the data, here's the reason for what the collaborative is offering to you as guidance and recommendations. And then we all work together to be accountable to fighting this virus together and trying to live appropriately while doing so. So I think that's also an important aspect to know, that this is a team effort and not just the collaborative.
And I guess I would comment, I think, we have good epidemiologists and scientists that give us some insight into where things may go in future weeks, but some of that is limited. The nature of a pandemic is that you can have outbreaks based on things you can't predict, and allowing the ability to change recommendations based on what's happening in real time is really going to help things going forward. So again, I think businesses and people in the community and educators, it would be reassuring to know how things are going to be in September, October, and November. And if we had the ability to predict that, I think we would. But I think we need, nature of pandemics, we need to look at things to date and make recommendations based on that. And I think people in the community need to be informed and able to give us feedback, but respond to things on really on a week-to-week basis.
A question from Tyler at WKBT. When new data is released every week, should our schools and businesses keep changing their safety protocols?
So I'll start with that, and then others can join in. We know that schools have been planning for months. We've been, partners at the table there, and I just want to say that schools have, are trying to set plans based upon something that is if then, if this, then that. And I just want to share that we know that the state of Wisconsin is working on a decision-making framework that will support the schools to provide some of that as well. So it isn't just the collaborative and the tool that we have that will support the schools. Additionally, I think, that schools should receive the guidance and the recommendations just as everyone else in the community, and do their best to follow those guidance and recommendation pieces. But I have no doubt at all, knowing the level of planning that the schools have done, that they can be responsive to that, and that will hopefully not present a challenge to them, because again, they have done very good planning efforts so far, and they are absolutely going to do their best to protect the staff and students in schools.
Any additional media questions today? I see one more from Marcus.
In last week's, we saw a younger person had tested positive. Are we seeing more younger people, and is that a concern?
I can only speak to our experience in my area. I don't think we've seen a spike of younger positive cases. I can tell you definitively we've not seen a spike of younger patients in our hospital facilities. So I would say we have not seen a spike of younger patients is my experience.
Yeah, I concur. I think the data is what it's been. There's been low numbers of young patients that have been positive sporadically, but we're not seeing any major trends along those lines at this point. It still continues to predominantly be the young adult population in our community.
And then I'll just add that once the tool is live, that is a feature that you can sort on the case data page. There's a slider tool, and we'll show you how that works when that is live. That can show you by date range, and it gives you demographics to include cases that are in different gender and age demographics.
And then what more can you tell us about that possible reinfection case?
So I'll speak up, I guess, just in a general sense. I don't have specific details about that case. I wasn't involved in that case, but I think I do have a message I shared with our organization and our employees, and I'll share it with the community here. This idea of reinfection, it's an idea and it's out there. Really, to this point in the pandemic, 5 months in, there has not been a conclusive, without a doubt, case of reinfection that's been confirmed. What is an issue and what is out there, and it's a confounding factor that just makes the interpretation of some of the testing difficult, is once someone is diagnosed with COVID-19, they can continue to shed that RNA, those fragments of the virus, for weeks and months. The CDC has come out now just within the last few weeks and said anything less than 90 days, we know they can shed in that period of time. But viruses don't follow 90-day protocols. And so we also know, and I'm already familiar with cases that have shed virus for longer than that. So shed virus particles. This is kind of like going hiking in the hills, and it's the difference between seeing the shed snake skin versus the real snake. It's evidence that something was there, but it's not an active problem one needs to be worried about in terms of infection and symptoms. Could there be,
Dr. Kowalski?
Yeah, could be reinfection at some point in the future. We may find that. It would not surprise me, but right now I think that's probably not the real predominant thing we're dealing with as much as viral shedding.
Yeah, our infectious disease experts have agreed with that. We have not documented any cases of reinfection. The nature of the viruses, the proteins of those viruses is what we test for when we do nasal swabs, and those proteins can stay in the nasal cavity for a long period of time. And we've even had some people that have, you have to have 2 positive or 2 negative tests before you can leave our facility sometimes. And we've had people have a negative test and then a subsequent positive test. And it isn't though they cleared the COVID virus and then were positive again. That was a persistence of the original infection.
And just remember that the virus is still very young, very new. We're still learning a lot about it. And, even a tentative possibility or a definition of such is something that has to be studied and has to have additional evaluation before we'll really know for sure. That's how these things work. So again, it sort of comes back to it's a pandemic, and things are not always black and white, and we have to be flexible.
If we can, one last question from WKBT. What recommendations do we have for schools starting the year online after the first 30 days? And will we have COVID concerns into the winter months?
Yeah, well, again, I think you already heard us say that we can't project forward, more than, we really can forecast a week maybe, but we can't project forward a month or 2 months in time. So I think that we have to watch this each week and try to see where the virus is in our community and the level of concern. If that stays the same, goes up, goes down. Those are important aspects when it comes to planning for anything, to include schools, potentially being in person or hybrid models or fully virtual. That makes it really tough from a planning perspective, but that's really, we have to just be planning for all of those potential possibilities.
And I don't see any additional questions, Jen.
Okay. Well, thank you. I just want to appreciate our media partners and our community for listening and hanging in there with us through this transition. We all really believe that what we have here will serve our community well going forward. I thank Dr. Kowalski from Gunderson and Dr. Fitzgerald from Mayo and the folks in my department who have helped support where this has gotten so far. We've made a lot of progress. And again, I do feel very hopeful about what this will provide to our community. And really the takeaway here is the recommendations that we've shared. I've said from the beginning of all of this that we know what to do. And while that may change week to week slightly in terms of how many numbers of people can be together, it really is more about washing your hands, physical distancing, that 6 feet, and wearing the mask. Those are really the key action items, and staying home if you're sick unless you need to seek medical care, and then calling ahead. So we thank you for continuing to have those actions, and hopefully we'll see you next week.
Thank you.
Thanks.